Welcome back again to the Sensible Medicine Roundtable discussion. I'm joined by Professor Adam Sifu from the University of Chicago and Dr. John Mandrola, cardiologist from Louisville, Kentucky. Gentlemen, it's great to see you again. We have a great lineup in store for you. First, we're going to talk about how to interpret studies, particularly when there's residual uncertainty, which there always is. Next, we're going to talk about 7 doses of vaccine, I guess 5 boosters and 2 bivalent boosters. It's like I always say, 7th one's the charm. We're going to talk about that. And then if we have time, we're going to talk about ABIM and certification, board certification. So gentlemen, it's great to see you again. Why don't we have Adam kick this off? So this is all about uncertainty in study design. Whenever you run a study, you get, particularly a randomized study, you'll get some point estimate, but you also get a confidence interval around that. How do you think about this, Adam? How did you make sense of it? Why don't you kick it off?
Yeah, you know what I could do? You want me to show slides? I have some sort of basic slides from a course of sort of how I always discuss p-values and confidence.
I'd expect no less. I expect no less than slides.
I got slides for everything, damn it.
Like a fourth-year student all over again.
Totally. Totally. Okay, here, I'll share my screen like a good Zoomer, okay? Here we go. And then you guys can actually critique my slides and tell me that I'm getting it all wrong all these years. My students will have post-traumatic stress disorder seeing this. So p-values are kind of old school, right? I always pitch that, we're used to saying, oh, p equals 0.05. This is wonderful. This passes the sniff test. So p-values, I, as a non-statistician, say, they're a probability of getting a result, or a difference is what we're always interested in, at least as extreme as the one you found if the samples, which are like the treatment control group, came from the same population. And so what that means is that if you get a low p-value, it means the groups are very unlikely to come from the same population. So the treatment, the intervention that you've included in your study means that it's changed those two groups, right? And so that's how we use p-values. So this is just sort of an example that I always throw. I think this is actually from the West of Scotland study to go way, way back. So, if you're told, okay, the relative risk is 0.7 and the p equals less than 0.05, that means there's less than a 5% chance that the groups being compared are from the same population. So basically less than a 5% chance that your intervention had no effect. People often say that, okay, there's less than a 5% likelihood that the difference between the two groups was due to chance. I know statisticians go nuts when they hear that, but a lot of people say that, and I don't know. I'll stay out of that. Confidence intervals, I always find, are a little bit more helpful because not only do they give a level of significance, but they kind of give a level of certainty. The definition really is: were we to repeat this study with multiple samples, the calculated confidence intervals, and the confusing thing is the confidence intervals would be different every time you did this study, would encompass the true results 95% of the time. And my sort of non-statistician brain, the way I flip that around is, well, if we repeat the study 100 times, you'd get a result within the confidence intervals 95 times. And that's not perfectly right. The definition on this slide is more correct. And so when I use these, I always think, okay, confidence intervals, 2 pieces of information. You get a level of significance. If confidence interval crosses 1, the result's non-significant. That's by convention. And precision, right? And I think this is probably what you guys have been talking about so much lately. If you have 2 studies, both have a relative risk of 0.7, but one has confidence intervals 0.62 to 0.78, that's a pretty precise study, right? You have a very good sense of how effective this intervention is. While on the other hand, if your confidence intervals go from 0.1 to 0.95, this intervention could be hugely effective or could be barely effective at all. P-values really only give you one piece of information. It says, how likely is this result to be, I don't know, true? How likely were we to reject the null hypothesis? So maybe that's sort of my basis as a place to jump off for people who don't do this all the time.
But Adam, the p-value thing, is that similar to the same population? Would that be similar to saying if you if the null hypothesis means that there's no treatment effect,
Right.
then the p-value is really a measure of how surprising the data is if there was no effect.
Absolutely.
And so, but it's kind of a made up hypothesis that there's no treatment effect.
Absolutely. Because we're going, and that's getting into more of, I think, the sort of Bayesian way that we look at these studies, right? You never have no idea that the treatment's going to do something. Sure, there's uncertainty, right? There's equipoise as we go into this. But every study that anybody ever reads, they go into it with some like pre-study probability that the intervention has an effect or doesn't have an effect.
Yeah, I think that's really nicely stated. I guess the only things I just to point on that is that, to defend the p-value and the frequentist a little bit, because you're exactly right, John, it assumes you're sampling from the same, you have a jar of M&Ms, you want to know how many yellow M&Ms you're putting your hand in twice, the same jar, or as you're putting your hand in two different jars, right? So it assumes you're sampling from the same population, and do you see result this extreme or more extreme? But the beauty of it is, in a world before we had computing power, computers at our fingertips, this was the most straightforward way to make this calculation, on a day-to-day basis. You can look up these values in tables and actually have some conclusion in your practice. And I think that's why frequentist statistics took off. And then for the confidence interval, I think Adam's definition is spot on. A mistake people make is they say the probability the point estimate is in the confidence interval is 95%. But that's wrong. It's either in it or it isn't in it. And it's really a long haul statistic. It's over doing this many, many times over. But this is the crux of it. Why don't you bring the clinician in, John? Bring the clinician in. How's a clinician thinking about this? And let's talk about that.
So here's what I want to know. I want to know, well, we have these New England papers, and we have, JAMA papers, and we have these papers, and we have a result, and then we're forced to conclude based on the confidence intervals and the p-values, and it seems like there's a little bit of variability in how we conclude. Okay, for instance, if you take a really, really important trial that goes against my grain is this Dan Kvass trial. Dan Kvass was a Danish trial looking at screening, cardiovascular screening in a population, and they found that there was, and it was a mortality trial. They found that the screening program, the relative risk or odds ratio or whatever hazard ratio was 0.95, so 5% reduction. And the confidence interval went from 0.90, 10% reduction, to 1.0, no reduction. And New England made them say that there was no significant difference. So that seems really like, and the p-value I think was like 0.06 or something. And so they had to declare. But if you look at that 95% confidence interval, you sort of convert it to the probability of benefit, it seems like the whole confidence interval was pretty much, below 1. But then your whole point with this mass study is that we had a hazard ratio that was, what below 1 and above 1 by almost the same amount. And, people are saying, well, that's inconclusive. And so my question is, what's our threshold for conclusive and inconclusive? And I'm asking, I really don't know.
My bias in this debate, and we'll bring in Adam in a second, but my bias is whatever you want, you just have to be consistent. And so I actually agree with the statistical purists on the internet, like Frank Harrell from Nashville, which is that if you run a study and you have a wide confidence interval, you're actually should be quite inconclusive about your results. There's still a lot of uncertainty about the true point estimate is. It could be you run it many, many more times and crank up that sample size. It could be a benefit. It could also trend towards null. It could even be a decrement. So I actually agree with him that he's right. But the point I want to make is I just need you to be consistent. So if you're going to say that for masking, we need 25 more studies to tighten up that confidence interval around null, then you got to say the same thing for all of the other things in medicine that somebody could feel that way about. And I just show my figure. It's not a slide. I'm not as polished as Adam, but it is a figure from a preprint we have up. And I'll give a little bit of the backstory. The preprint's entitled Interpretation of Wide Confidence Intervals in Meta-Analytic Estimates is the Absence of Evidence of Absence. And we're looking at Cochrane, and we're basically asking, how consistent are they? And what happened was, of course, The mask study came back and it had a wide confidence interval, relative risk 1.01, 0.72 to 1.42. And, the Tom Jefferson, the first author, says there's just no evidence that they make any difference, full stop. There's no evidence that they make a difference. That's what he says. Carla Soares-Weiser, the editor-in-chief, says many have incorrectly claimed masks don't work, but that's wrong. The results are inconclusive. Then what we did was, Sarah Miller, a student here, myself, Jordan Tuya, we just pulled the last 20 Cochrane reviews where it had a similar result. The relative risk is null. The confidence interval is wide. Jefferson shown here, it's one of them. But there's some that are even wider, 0.59 to 1.65. And there's some that are even more unfavorable, perhaps, like Kim. Kim is, it's more favorable. And there's some that are more unfavorable on the other side. So Kim is one of the ones where, if anything, it's like Dan Kavas, right? The upper bound goes to 1.04. And we just pulled what Cochrane says verbatim in their conclusion about these things. With moderate certainty, remdesivir probably makes little to no difference for all-cause mortality. Compared to expectant management, there was no clear difference of induction of labor. Dose-escalated RT probably results in little to no difference. The hazard ratio is 0.66 to 1.04. And then finally, wearing masks in the community probably makes little to no difference in the outcome. And so I guess the point of this article is not to end this debate, which will go on forever. It's just to say that what Tom Jefferson did is consistent with what they all do in Cochrane. These are just the last 20. We're not even this is just consecutively picked. And if you want to tell me that for masks, we have to just say it's inconclusive, we don't know, then sure, but do that for everything else too. And then show me how you're going to talk to a patient. I really want to know that. You're going to go in the room and be like, well, I could offer you vitamin D and vitamin E. It's inconclusive. Ivermectin's inconclusive, So that to me is what my issue is. I just want consistency. And I don't care I'd rather be precise and wrong. No. But you know what I mean. All right, Adam, what are your thoughts on this?
So first, I've been incredibly busy, so I've been completely off Twitter for the last couple of weeks.
Congratulations.
Thank you. So this is the first time I've seen that, and I think that's a great paper. I love how you went through that. I love that forest plot, even though it's not nearly as nice as my PowerPoint slides. But and I really do agree with everything you said. On the one hand, I think we do need to agree on, some level of, certainty, right? Where we draw the line, what our acceptable alpha error is. I remember years ago, I gave a, reversal talk to a lay audience, and a lay audience in Hyde Park in Chicago is not like a lay audience everywhere else. And some physicist stood up and was like, 95%, 5% alpha error. What the hell is that? We go to 7 digits to say that we're not making a mistake. But I think what this brings in nicely is it really is different for me as a clinician, right? If the results of a study is a relative risk of 1.01, right, with fairly wide confidence intervals, sort of symmetric confidence intervals around there, I read that as, this is negative. And yeah, we could do 1 million studies and those confidence intervals will probably tighten up, but it'll probably still be negative, right? But bringing a little bit into the Bayesian look that John said, if there's something that I go into with, I think this really works, and the confidence interval is, the relative risk is 0.9, and the confidence intervals are, 0.8 to 1.01, I sort of look at that and say, wow, this effect is probably small. There's a possibility that in the next 10 years, as we do more of these studies and see some meta-analyses, we're going to accept that this has a significant benefit. And if I sort of think that that's likely something that's going to happen, I'm going to act on that paper in that way. Or at least I'm going to counsel the patient in that way, I should say.
That's interesting.
Yeah, but let me push back. Let me push back against that and say, but that gives like proponents of something a lot of leeway, right? If we don't have a threshold. So let me try and share my screen, and I'll show you something. I want to show you a trial in EP. I don't know. Can I share my screen?
Yeah,
or no?
yeah. You can hit the share
share
button.
Screen.
There you go.
Okay, so Google Chrome. All right. Let me show you Can you see this now?
Yeah. One, you have too many tabs open. I can see that.
All right. So this is Cabana. This
Yeah.
is antiarrhythmic drugs versus ablation. And there's a lot of ablation proponents, and this was a big trial. So let me show you here. Here's the primary endpoint, which is, a MACE endpoint, 0.86, right?
Yeah.
14% reduction.
Yeah.
And the confidence intervals go from 0.65 to 1.15. The p-value is not significant. But if you're an ablation proponent, you can point to that and say there may be a 35% reduction in major outcomes with ablation. Now, it could be 15% worse, but it could be 65%. So it's a 14% point estimate. So you have a p-value of 0.3. It's not very surprising data given the null effect. And so this is the problem with, Adam, your point of saying, well, I believe this works. I'm an ablation guy. I make a lot of money doing it. And so look at that lower bound of the confidence interval. And so that's what my question is as a clinician is I just, I just worry about this sort of this non-threshold way of interpreting these studies. And
John, that's so well said, because I look at that result, right, and that's negative to me, right? Like, no question. I'm like, we don't know anything based on that, right? P equals 0.3, wide confidence intervals. Geez, give me a whole bunch more studies. And I think as I kind of read into the future, and this is, I always hate to say, oh, this is based on 25 years of looking at studies. In 25 years, if the technology doesn't change and we continue to study that, even if we find out that's beneficial, right, after another 12 studies, we're going to find that the benefit is so small because we're going to need so many people to show significance there, right? That those results in themselves to me are like, we got to go back to the drawing board and we got to do something different.
Yeah, but they randomized 2,200 patients across the world in multiple centers and spent, this was a NIH funded study. It's spent gazillions of dollars and 2,200 patients.
You need 22,000 to see the benefit, John.
But I think Adam, I want to make a point to the listeners. What you're saying, and I appreciate this, is that if you have to randomize that many patients, and if you have to do 10 more studies to show something, has a precise confidence intervals, then that is information in and of itself telling you that there's probably not a major difference between using antiarrhythmic drugs or ablation or drug A or drug B or whatever.
And then I want to push on the, go on.
Let me just say, I think a good example of this, to take it away from this silly electrophysiology thing which affects basically nobody, is the issue with mammography. Right? Yes, if we randomize 3.5 million people, we might actually find that doing mammograms is definitively useful. But boy, that's a lot of people with a lot of harm to put through mammography.
It's actually the problem with all screening, including colonoscopy. I know there's a debate winner here who's he may have won the debate back then, but now the shoe's on the other foot. The other point I want to make is that, we have to have some intellectual honesty in the sense that I don't think ivermectin helps COVID. I think we've done enough studies and we can stop. I don't think vitamin D, helps anything. Besides maybe actual rickets, I don't know. I don't think it helps anything except rickets, And I guess I just want to say that the same people who want to say that mask data is inconclusive want to also say that the ivermectin believers are morons, and they have basically the same confidence interval. And so all I want to say is, you just have to be consistent. So either you all are in the same game where it's okay for them to keep calling for more ivermectin studies and it's okay for you to be calling for more masking studies, or you're in a different game. And then the point about the pretest, the Bayesian part, I like a lot of things about Bayesian statistics, but the one thing I have never seen anyone solve is what is the pretest probability? It's often your gut, and we know our guts are not reliable in this business. And if anything, we're too optimistic. So I think that to me is what I find to be the reason why this particular issue got under my skin a little bit was, I saw the Cochrane editor scolding Tom Jefferson, and then I just looked through 20 Cochrane. I'm like, he's basically, and then I also found out they actually have guidance for the language they use, so he actually has no leeway. He did not even have a choice. He just did what everyone is doing in the reports. And so either we're going to say Cochrane is all wrong, all these reports should say inconclusive, and thus if you want to skin and care interventions for infants in preventing eczema, that should also be, up for debate too. That's up for debate too, whatever you want to moisturize the infant with. Or we're going to have to say that there's just, the last point, there's just so many hypotheses that if we don't have some sort of strict test for what's going to make it, I guess what stops us from just doing 1 million studies of everything under the sun? And what is the burden? Do we have to keep doing studies until we show the confidence interval it's definitely killing people? Like, we got to run it until you got a dead body count on I don't know. So to me, I just come back to the fact that, as Adam pointed out, that if I saw that study you just showed there, what was that? Cabana? Yeah, if I saw Cabana as a non-EP doctor, I'm like, that's just stone cold negative, and I don't want to hear about this again. And I'm annoyed that you even told me the first time, because I don't care, So
but the problem I think the problem, I love the Bayesian thing, because just to bring it to the listeners, the idea with the Bayesian approach is that you're trying to find a probability of a benefit once seeing the data, rather than what the probability that is of the null hypothesis, so the made up hypothesis. But the problem with the Bayesian thing is that how you believe or that pretest belief, just like it would with chest pain in a stress test, plays into it. But I think what the Bayesians would say is that you have to calculate the probability of benefit with a pessimistic prior, with an optimistic prior, with a neutral prior, and you have to calculate what those probabilities are after seeing the data, and that makes it complicated. And people don't like complicated. I think that complicated is okay, but I think that's the problem with the Bayesian statistics. You could take a null trial
and
like
make it
this
positive.
Cabana that I just showed you, and I bet if you converted this to Bayesian, there'd be a substantial probability of ablation better than drugs, because the confidence interval is wider on the benefit side than it is on the harm side.
Two things are still binary in this world. One, do I offer it to my patient? And two, does the insurance company pay for it? And that's the challenge with, you can be as nuanced as you want, but at the end of the day, are we going to offer this new, there are many drugs that don't come to market with a confidence interval like that. What the FDA is saying is that you don't get to offer that drug to your patient, no matter how, you can do all the Bayesian you want. They're not going to let you offer the drug. And then there are many drugs and procedures that we don't reimburse for. And I think, to me, at the end of the day, those are the two binary questions. Adam, you're going to say?
I'm not sure if this confuses things or not, but John, you sort of alluded to it. I think that one of the reasons that we get into this problem is that, physicians have to be Bayesian when they're diagnosticians, right? Because we all do a test because we have some level of pretest probability, right? Some level of suspicion. We do a test, and then we have to incorporate that pretest probability into those test results. And we can say, oh, well, this is easier because you can look up in a book, if I have a overweight 40-year-old woman with right upper quadrant pain, what's the likelihood that she has gallstones? And then I can look up the sensitivity and specificity of a right upper quadrant ultrasound, right, and come up with an answer. But in fact, that pretest probability is not something you can look up in a book, right? And that's pretty soft. And so I think, going through our careers, doing that every day, managing patients, I think it maybe sets us up for errors when we're looking at studies, because we're a little bit more used to bringing in information that we know, when if you're looking at Cabana or Bankovas or whatever, we don't really know, or masks or anything, because that's why we're doing the study, because we don't know.
That's really well said. And the only thing I'd add to that is that maybe the bias that all three of us share, just having been in this sandbox so long, is that we just think the pretest probability of a lot of things is just really low. We're not nihilists. We're not like it could never work. We just think that in the grand arc of human history, most things didn't pan out the way they did. And maybe because we were all interested in reversals to some degree, Adam with his Women's Health Initiative sort of experiences, and John with, cardiac antiarrhythmic suppression trial. Those are ones that probably, let's just take CAST. If you ask the cardiologists in 1985, what's the pretest probability that CAST will be a positive study? They're going to say an optimistic prior, right? And actually, I'm curious to go look up, and we are going to look up the confidence intervals for all the reversals that we take for granted. But I did one autologous stem cell transplant. It was very wide, So I just think that that's just not the way we've been practicing for 30 years. Like CAST was enough to end that practice. It killed it. I'm going to look it up.
But CAST is not a good example of this uncertainty because the confidence intervals were so much greater on the harm side. I mean, it was pretty clear that there was harm. In fact, if I remember,
one of them killed people. Yeah.
Yeah. So,
I'm looking at it. The relative risk of death was 2.64, 95% confidence of 1.6 to 4. Oh yeah. Okay. It really killed him. Okay.
Yeah. You were at the least, you were 60% worse, right? Yeah.
But maybe Women's Health Initiative was more closer to.
That was close.
Women's Health Initiative, I think, was like 1.2 or 1.3 as a lower bound. But yeah.
That Dankovas, however you want to say it, article drove me absolutely nuts for so many reasons. We could do an entire podcast on that. And that's a study that I go into with negative priors for so many reasons that not only do I think screening, for, let's just say, coronary disease, risk factors for coronary events is a bad idea. I think the downstream consequences of that screening is a bad idea. And then I felt like that study was designed in a ridiculous way, but I can't shut up.
But the problem is it was a Danish study and Danish environment. That's another thing. Trial environments play into things so much, right? Because in Denmark, you're not going to have the downstream harm that we have here with, like, say, coronary artery calcium screening and these sorts of things.
So listeners who want to hear this discussion, we will do this paper someday. Just a sneak preview that someday soon, the three of us may be offering an online clinical trials course. This will be a little bonus. We're going to put this pearl in there. That's a teaser for the faithful fans. The last thing I'll say as we conclude this topic, somebody accused me that I only did that preprint for the clicks. And I want to promise you one thing. There ain't nobody out there who cares enough about confidence intervals to be doing that for the clicks. You do that because you can make all sorts of things, but that's not for the clicks, okay? Ain't nobody interested in that paper on SSRN, the preprint server. Okay.
I'll second that, Vinay, because I'll just tell you that having writing for Medscape, I'm pretty much not allowed to, not prohibited from it, but just told that if you write about p-values, confidence intervals, statistics, nobody's gonna read it. So
so when we title this podcast, we can't put that in there.
You guys are crazy. It was like the lead story on 60 Minutes last week, wasn't it? All about confidence intervals.
Yeah, confidence intervals. That's riveting. Well, the Sackler stuff will be there soon. That was great. Okay, let's talk about seventh dose is the charm. Seventh dose is the charm. I don't know. I mean, my only thoughts, and then I'll kick it to you, Adam. My only thoughts on this is that, I have no doubt that this is a good vaccine. Like, statins are a good medicine, and like everything that's a medicine, there's a risk gradient. There are people at high risk who benefit a lot from statins. If you've had an MI and you have high cholesterol, like 4S study, you get a massive reduction you get a massive benefit from taking that statin. If you're a 16-year-old who has mildly elevated cholesterol, I honestly have no idea, and I don't think any trial has even tested what happens if you put those people on statin, and so there's this huge gradient. That's true for statins. I think there's also this question of diminishing returns. Like, I have no doubt that the COVID-19 vaccine works great in a 70-year-old, dose 1. And we do know dose 1 is like 90% reduction in hospitalization, and then each additional dose has something, but it's got to diminish over time. And what I think is ironic about this 7th dose bivalent approval is two things. One, you have Peter Hotez and many others saying specifically, one of the reasons why they gave this EUA was that the Biden administration has a surplus of bivalent booster, and it's going to go bad. So if we don't, you either clean out that refrigerator or it's going to spoil, my friend. So drink the milk, John. I know you're not thirsty, but drink up that milk. That to me rubs me the wrong way. 2, they have no data at all, in my opinion, that the second bivalent booster helps anybody. We can talk about these observational studies. That'll be fun. And 3, they have a population that doesn't really want them. We got 16% bivalent booster uptake for the first one. This will be a subset of that. And 4, we have less and less evidence for each additional dose, when ironically, you need the biggest study to find the marginal benefit now because, the biggest benefits were in the beginning. All right. Adam, what are your thoughts on this 7th dose?
I'm going to be a little more gentle.
Good.
So first, it's the 6th dose, right? So it was 3 initial shots.
Okay.
We gave a 4th to people who were at high risk. The 5th was the first bivalent. So this is the 6th, the second bivalent, right?
I thought you could get 2, the 4th and the 5th, if you were at high risk. And then this, I'm going to look it up. I actually had my fact checker count, but okay. Let's 6 or 7.
So
well,
we're either at 6 or 7.
Okay, fine. Okay.
And so, I think the read for people who are in favor of this, right, is that we have some data. It's not terribly good. They're observational studies that show if you compare people who have chosen to get a 6th dose in addition to their 5th, have some benefit in fewer hospitalizations over 2 to 4 months. The efficacy is about 8%. Okay, so that's about 1 in 1,000 people who get the shot get some benefit from it. Now, the flaws of that are huge, right? We don't approve vaccines based on observational studies. It's impossible to know if people who chose the shot are less likely to benefit because they're super careful people who are not going to get COVID and do everything right, or they're actually at higher risk because they're getting the shot because they actually have problems. There's just no way, whenever you try to figure out which way confounding goes, usually you're just adrift. So, approving this in a way, I could care less. You guys might think there's some harm to this. I don't really think there's much harm to this, except it further, lessens people's faith in public health in America, which is a disaster as it is. But, me as a primary care doctor, oh my God, having to counsel people who are now like, I got to get this shot, and sort of pull them back to say, look, this is the decision you should make. And if you want to get it, it's fine with me. You're probably not going to get much benefit from it. If you don't want to get it, that's fine. I just think once again, we should be doing a better job kind of educating the populace about the decisions they're making about COVID prevention.
That's a lot of great points there. John?
All right, so I have 3 comments. First, I want to disagree with you when you said that you have no doubt it's a good medicine, because I don't think the modifiers good or bad belong on medical interventions.
Fair point.
Because anything can be good or bad depending on its usage. So, that's So that's number one.
And that's what I really meant to say. What you just said. Anything can be good or bad depending on how you use it. Fair.
Yeah, and dosage, depends on toxicity. Depends on dose. That stuff. The other thing I would say about the evidence about a 6th or 7th vaccine is that trials, I think, or evidence has an expiration date, right? So in 2023 is a lot different than 2020. Sure. And you have different levels of immunity, you have different viruses, you have all this change. And I would argue that the trial setting or the evidence setting right now is so much different than it was in 2020 when it's just obviously different. And as a backup of that, I will tell you that in my world, in cardiology, one of the most common things we do is put in a defibrillator in patients who have heart failure, because the 2 seminal trials in 2020 were around 2000 were positive. So 20 years ago, trials were positive. However, everything's changed, right? Sudden death has gone down. Medicines are better. And the last defibrillator trial Danish was totally negative. And now in Europe, I read that there are going to be they're going to repeat the seminal trials.
I saw
because
that.
because the trial environment, things have changed. So I would say that the evidence for a sixth or seventh booster now is much different than it was back then, and we ought to have new evidence. And the third thing I would say to Adam's comment about harms of the vaccine, and you just said offhandedly it lessens trust in public health. And to me, this is one of the biggest lessons from the pandemic, is that this is underrated as a harm. I mean, because when we promote things with poor evidence, and anything that shreds trust, I think is a huge intangible harm.
I agree with all of that. And the things that I'll just add to the pile. I mean, the one thing that Adam says is, like, of all the things, it's, if somebody over the age of 65 wants to do it, do I think they're like jumping off a bridge? No. I mean, whatever. I mean, maybe there's a small benefit. Maybe it's a waste of your time. Maybe you'll get some sore arm. Maybe you're unlikely to have myocarditis because the first 6, I'm going by the 7th assumption, the first 6 didn't do it for you, okay, and you're not in the target age group, etc. One thing I think it teaches us is that this is for 65 and up, or those who have a risk factor. This same FDA said in 2021 that they cannot give an approval for 65 and up because the American people are so stupid. They won't know. You got to have a 1 dose for everybody, whether you're 12 years old and 16 had COVID, or 85. We can't have different based on age. That's what they said. And now, of course, now they acknowledge that, like everything else in medicine, we know how old we are and we can easily do it. It's not so hard. So that's strike number 1. Number 2, I think the observational data, Adam's point is you don't know which way the confounders go. I agree. The trust, I think, is important. And then the point I want to make is Pfizer has $100 billion in 1-year revenue, which I think is the most of any company in human history in the pharmaceutical industry. They had so much cash in their pocket. Borla can't even walk without a $100 bill falling out of his pocket, that they bought Seattle Genetics. They bought Seattle Genetics at market cap $43 billion, which is such a premium of Seattle Genetics. And Seattle Genetics, the first thing they did was they had a failed phase 3 study. The SWOG study screwed them. I mean, why is the company buying that company? That's what you do when you have just too much cash is burning a hole in your pocket. And in this economy, where are you going to invest that money? You just got to acquire. But why do they have so much cash? And I think it's because this FDA is like, they are like, this FDA is like Pfizer's lapdog. They roll over, let him scratch his belly. I mean, like, give him a challenge. Paxlovid, we still don't have good data for vaccinated people, boosted people. Each additional booster, we're not asking them to do anything anymore. In fact, I don't even know if they requested this EUA. They just got it. And then to your point about where we're not in 2020, I really think they have to stop using the EUA. Like, the EUA's emergency use authorization, it requires a federal declaration of an emergency, which legally they're holding on to that. But can anyone tell me, in all honesty, a 65-year-old runner who's skinny and healthy, who's had 5 or 6 doses of vaccine and had COVID once or twice, is facing an emergency such that you have to, like, alter regulatory requirements? I think that's wrong. And my last point, unrelated to this, I think mifepristone should be on the market. I think that's crazy talk to try to take it away. But I do think you should be able to sue the shit out of the FDA. And I want to see somebody sue them on a cancer drug approval or an Alzheimer's drug approval, because FDA ultimately is responsible to the people. And so people, you get yourself in court. So anyway, that's my thoughts. Adam?
Nothing else to say.
John, closing comments?
No, I guess the one thing that struck me all during the pandemic is why couldn't we all of our lives in medicine, we risk stratify, right? We use medicines and we use surgeries and procedures based on risk, and the idea that we weren't allowed to risk stratify people during the pandemic, when the earliest data was clear there was a major age gradient and risk factor gradient. And now, of course, we are using this risk gradient, and why we couldn't is just so mysterious. And I think that people understand that. And really, it was a real trust shredder, I think, because people are like, why we were mandating a 23-year-old person in a hospital get multiple vaccines, say post-COVID, when clearly that person's risk was low. Or yeah.
Well, I think, I feel the need to make this point, even though I don't believe it. The argument was, by vaccinating low risk people, we're going to help high risk people, right? Which there was a time that argument was reasonable because we didn't know any better. It didn't take long, I think, for that to become an unreasonable argument. And I think, a wise person once said to me that, you can motivate behavioral change in multiple ways. You can either do it by educating people about their own risk, about their risk to others, or you can motivate people through fear. Neither of those ways of motivating people is nearly 100% effective, right? Getting people to change their behavior is always nearly impossible. But the downside of motivating people through fear rather than through education is enormous. And I sort of think that that's what we're paying for at this point.
Well, yeah, I agree, Adam. I agree. And I don't want listeners to think that, but it became very clear to me, it became very clear to everyone that there was a problem with there was a, it wasn't stopping transmission. And so, the mandates went on way longer, and you say persuading people with fear is problematic. I couldn't agree more, but also it's possibly even worse with coercion, right? I mean, coercion we should have the highest level bar, right, when we start with coercion.
Well, I'm glad Adam made the argument, because I think that's an argument that a listener may be thinking. The two counter arguments I have is, one, if you actually look at the date that most of the mandates went into effect, the date was beyond the date we knew that it couldn't halt transmission. So that's a bit of a problem. But the second argument I make is that even in the beginning, where people thought it was highly effective, it wasn't clear to me that, like, if I got my own shot, that forcing John to get his gives an additional benefit to me. I never saw that sort of compelling case. But let's shift to the third issue, because we could go on and on about this. The third issue. The third issue is going to be about board certification and about these new rules for modules in Illinois State. But just by show of hands, who still has to mask in their clinics and hospitals?
Not me.
You're out, huh?
We're all done completely.
I think it's so interesting that which hospitals are the first to let it go and which are not. And I don't want to say anything because it's going to spoil some paper that I'm about to publish, but okay. But let's just say
I'll just say, you don't have to say anything about the paper, but I'll just say that the moment that it happened, an email came on a 10 a.m. on a Friday, and at 10:10, everybody was mask free. I mean, it was a similar that when the airlines announced no more masks, and it has just been wonderful to be able to communicate with people, and I'm just now getting over the idea of being naked, without a mask, and so it took a while to get rid of that, but it has been wonderful to be with people in a normal way.
Must be nice,
but
John.
COVID's not as dangerous where you are as it is in Chicago.
In Kentucky, I think it did a lot of damage in Kentucky, as in Chicago. Well, it's a great feeling. There's the old saying in medicine, you don't want to be the first doctor to do something, and you don't want to be the last. And all I want to say to these hospitals is you don't want to be the last one still masking. You're going to look pretty bad. All right, so let it go. All right, the final topic, board certification. Adam had a great tweet recently, and I'm going to try to paraphrase it, but it was something like the state of Illinois passed some law that he's got to do like 7 hours of training. You're going to tell us what it is. More modules. And I had a tweet complaining about modules, and sort of led into the discussion of ABIM board certification and how many of us have to renew every 10 years. And some of us who got in, I think before 92, 93, are grandfathered in, quote unquote. They never had to do it. why don't you explain your the new rules you're facing in Illinois, Adam, and some of these thoughts on board certification?
It's been very much on our minds lately because everybody's had to renew their licenses in Illinois. And there are just seems like every time the legislature meets, I'm probably guaranteeing myself that I'm going to get audited by saying any of this. Something else is added on, and it's right now, the last thing that was added was training in recognizing dementia. And what's hard is that every one of them makes some sense. Recognizing dementia is important. Understanding the risks of prescribing opiates is important. But as these things sort of pile one on top of another, it's getting to the point where I have to put aside, half days every now and then to get all of my compliance, adherence, mandates completed. And I feel like I'm an obsessive person who's really concerned about the care I take for my patients. And I find it insulting that above and beyond, the oath that I swore and the sort of blood, sweat, and tears that I spend every day taking care of people, that somebody checks a box in the legislature and says, oh, he's doing a crappy job unless he watches this, ridiculous video and answers 3 questions.
And can we talk about the evidence for it, which is like, I don't know, we're a field where you wouldn't give the patient a module on smoking cessation unless, like, let's say somebody came to you, Adam, and said, you know what, every one of your patients, I've got a 25-minute video, you're going to show them on this iPad, and you're going to say, before we debut this at the UC hospital, like, shouldn't we do a study to show that patients gain something from this? Or, and so similarly, your time is so valuable. And also we're dealing with burnout. And like supposedly I keep seeing all these doctors and nurses quitting and nobody wants to do this thankless job. And then they want to come in and like make you do another bullshit module. And so let alone the evidence that whether or not it improves outcomes, which I know they don't have. I'm just curious about the evidence of surely they know that anyone who does this module, here's what you do. You hit next until you get to the question at the end. You read the question, and if it's 90% of the time, it's such a common sense question like, which is the best thing to do for a patient? Listen to them intently. B, throw them down a flight of stairs. C, it's like, it's like, okay, listen to it intently. So like, don't they have data that nobody's even looking at it?
Yeah. And when you don't do that, when it really matters, right? There's no reason to avoid education or take shortcuts on tests if you know that the only person who's penalized by not learning that information is basically your patients, right? Like, we don't try to get good grades now for anybody else except the people we're taking care of. So already you have to trust us that like we're doing our best to take care of people, and that certainly if I want to learn something, I'm going to find much better resources than I'm being forced to go through here. I'm still annoyed about it.
John, you have a comment? I want to have a comment.
Yeah. So the issue that we're struggling with in cardiology is that the American Board of Internal Medicine, the positive side, and listeners will probably want to know that their doctors are fulfilling some degree of competence, right? So I want to go to a competent doctor and I want to have some sort of proof that this doctor is competent. And so the American Board of Internal Medicine, when I started, had a board exam, and to go into your field, you had to pass a board exam, and that was it. And then slowly and gradually over time, the American Board of Internal Medicine has added extra features. And of course, these all come at a cost. An exam every 10 years, and then maintenance of certification where you do a certain amount of hours, and regular continuing medical education doesn't count. Like if I go to a meeting and learn about EP or whatever, that may or may not count for the American Board of Internal Medicine. It has to be their brand. Okay, well then what do? Well, then they partner with the American College of Cardiology and HRS, and then American Cardiology will sell you a $2,000 booklet to study for ABIM. So it's this whole thing, and it's just been added on. But here's the problem. And I think Wes Fisher, we have posts coming from Wes Fisher, who's the EP in Chicago. He's been great about this. Here's the problem with this whole argument. It's all undermined by the fact that they let the oldest doctors, the ones who trained before whatever, I'm like 2 years from being grandfathered in. Oh. If you finish that early, then you're grandfathered in. You don't have to do any of this. And of course, if you're an older doctor, you're the one who should most do continuing medical education. And so it's completely undermined. And basically, I've come to believe that it's just a sort of rent-seeking way of making money for organizations and extracting money. And it's been given a tailwind because now most employed physicians have $2,000, $4,000, $5,000 of CME money. And so we've lost the will to fight because we're like, screw it, we'll just take it out of our CME money and do it. So I don't know what the answer is for certifying doctors, but this is a extremely flawed program.
They're just a good parasite, if you ask me. They see that doctors make a lot of money. You got a lot of blood in your veins. A good parasite will suck you, but it can't suck too much and kill the host. You know, that's a bad parasite. The problem is they're pushing their luck recently. They're pushing their goddamn luck with Adam's bill. They're pushing their luck because they're going to kill some hosts. And by that I mean they're going to get somebody in the age range of 55 to 65 who is going to do a few more years that's going to say, enough of this. And to be honest, I do work in a couple hospitals, and there's one hospital that keeps emailing me so much to do. And I really started to think, like, you know, it's not even worth the modules. Like, you know, I'm only going there a little bit, and I'll just do more at the other hospitals. I'll just do one set of useless modules. So, you know, no evidence. They're sucking our blood. Why does it exist? I think because the same way we have given our practices to private equity and to the administrative state, this is just another way we've let them abuse us, and we just take it. And we take it because, you know, even though the mosquito sucks your blood, you got a lot of blood, you know? So, like, yeah, like you say. And then the last thing is, you know, one of the good things Biden did was he, like, limited the amount patients can pay out of pocket for oral anti-cancer drugs in Medicare. He, like, capped it at 1,000, 1,500, something like that, rather than, it could be, like, you know, 7,000, and then you hit the donut hole. You know, it could have been really bad. And I think that's good, but one of the downsides is, the moment you don't have to spend out of your own pocket. As you say, John, the moment you have the CME money to do it, you don't have the skin in the game, and so you don't fight as hard. And so the grandfathering in was a tactic to prevent the doctors of the day from not accepting it. That was why they did it. You know, it was a political bargain. You spending CME money is a political bargain. This is a very clever parasite. It's sucking your blood and infected our brains. But I think the solution to the parasite is removal.
Go ahead.
Is to rip it out. Rip that fucking parasite out.
Yeah, but the problem, Vinay, is this, and I think the rent seekers know this, is that would require, if every doctor just said, tomorrow morning, we're done with this. We're not working until this changes. It would change in like 3 days.
Yeah.
But when I joined the cardiology group, we had 20 cardiologists. You couldn't get 20 doctors to agree on one thing. So the rent seekers know that there's enough people who are just saying, I can't be bothered with this. I'll pay to play. And so it's just there'll never be an organization, because doctors have other goals, right? We want to take care of patients. We need to pay our mortgage. We need to, you know, keep our kids in school. And so, yeah, I don't know what the solution is. And in fact, the legislatures can say other board, like there's a competing board. I can't remember the acronym, but there's a competing board.
It's like the national board or something. Yeah.
The problem is that the ABIM has captured the insurance companies. So then you'll get a letter saying you could be board certified by the other board, but the insurance companies will say, guess what? We're not covering you unless you're certified by ABIM. So,
Adam, closing thoughts on this issue?
I can't talk about it anymore. I'm so depressed.
I'll tell you though, I mean, I guess, you know, I always tell people this, which is like, they're so true. It's a thought experiment. And actually, let's close with this. This is the closing thought experiment. I always say, you know, you've made the right choices in your life and career, as if I came to you and I just gave you $100 million, John. Here's $100 million. And then I asked you, What are you going to do next week? Are you going to go into your EP lab and say, guess what, guys? I'm rich. I don't need your money. I'm done. Are you going to cancel your talks? Are you going to stop doing these podcasts on a Sunday? maybe that one. Are you going to stop being a writer and stop your podcast? And I honestly go through my own life and think about, what would I keep and what wouldn't I keep? And the answer is I always just come back to just where I am. Like I would take the Uber a little more often. Like I ride the public bus a lot and I bicycle a lot. I maybe sometimes when it's raining, I might take, a cab. But besides that, I think I would just do everything I still, the classes I teach, the clinics I do, the attending I do. It's all like what I would want to do even if I didn't need the money. Except these modules are the only thing that sometimes they test me. They're testing me with their module. And one of these days, if I had a lot of money, I would just like find a way to extract revenge on these module makers. Okay, so that's the closing thought experiment. You have $100 million gifted to you, John. What are you doing differently in your career? And then we'll do Adam, and then we'll close.
Yeah, I think that would be a real struggle because we all have our pegs that we hang our self-esteem on, right? That gives us meaning. And if you didn't have a peg, if it wasn't mastering conduction system pacing or writing in a beautiful way or clear way, if it wasn't a good podcast or giving a good talk, taking care of patients, what would we get meaning from? And so, yeah, $100 million that's a lot of money. But I can't imagine, just going to the AT&T store and getting a different phone and saying, see you later. I think I probably would do the same thing for a while though, because it gives meaning.
Would you cut back on hours? Would you change anything?
It's really hard, right? Because I'm 59 years old and I've never worked harder in my life. Travel, as you know, is hard.
Yeah.
Preparing talks is talks don't make themselves. So I don't know. I might say no to certain talks or travel, but my work is I can't complain about my work. It's pretty nice job.
Adam?
I am 56. I've got what I think 4 more years. And I think what I would do is I would wait until a month before I was already planning on retiring and take your $100 million then, because then that would pay for some nicer travel during my retirement and make things easier for my, grandchildren, great-great-grandchildren, whatever. So I'm just going to scam you out of your cash at some point. But right now, I think we're all in the same boat. Not only do our professions define us, but I feel like I've made good decisions. I'm very happy with what I'm doing, and we're well compensated. But I couldn't ask for anything more.
Wow,
I would buy a couple of new bikes. And
yeah, me too.
I would have the highest level bikes, and I would have a gravel bike, and I would have another mountain bike. And I would have a couple road bikes because, Italian road bikes, they're great when they're working, but they break down a lot. So I would have one for when it breaks down. Yeah.
I'd buy more electric guitars. I'd buy more I'd buy more bicycles like you. I'd get, certain derailleur that I'm eyeing, a certain power meter. You're right. But in terms of work, well, I think that's the closing thought, which is that I think maybe this is also why we're actually friends in real life, at least I think, which is that, we all actually, despite all the complaints, to do something where you do it for free, really, like you do it, you wouldn't do it for the money. That's a privilege. And I think not all the doctors I know feel that way, especially in this day of burnout, especially with that. Huh?
I'm not friends with you guys.
Let's just be clear. Okay. So on that positive note, we'll be back next week. Thank you so much, Adam and John. This has been a great discussion.